For our last formal speaker for today, I would like to welcome back to the stage distinguished Professor Richard Osborne from Swinburne University of Technology. He's going to talk to us about why and how to use health literacy development to improve health and equity in the mental health sector. Now, you've seen Richard before today, but Richard Osborne is a professor at Swinburne University of Technology in Melbourne, Director of Centre of Global Health and Equity and an advisor to the World Health Organization. He works in areas such as epidemiology, health services research, implementation science and health policy. For most of his career, he has held prestigious Australian National Health and Medical Research Council fellowships that have focused on research methods that accelerate innovation, implementation and equity. For the past 10 years, his team has had far-reaching international impacts on the field of public health, particularly in health literacy development. His team has developed health literacy surveys that have become widely used, including national government surveys. His health literacy questionnaire, HLQ, has been applied in over 700 studies, including population surveys in Australia, New Zealand, England and France. His team developed and implemented new community-based co-design methods to build and scale up public health interventions. The most widely used method is called the Ophelia, which is optimising health, literacy and access process. Ophelia was recently highlighted by the World Health Organization as a process to accelerate impact on non-communicable diseases and health equity globally. With WHO's global coordinating mechanism for the prevention and control of non-communicable diseases, Richard's team developed the concept of health literacy development, which is included in WHO's recent health literacy centrepiece, which is a 4-volume report on health literacy development for the prevention and control of non-communicable diseases. So this, what to do and how to do report has been classified as a global public health good. That's amazing. He has over 300 publications in international scientific journals. Many of these papers have been widely read and cited, having been cited over 50,000 times. That's amazing. Your impact rating must be off the scale. Grant bodies must love you. No? So over 50,000 times. He's been named as a Claravate, highly cited researcher in 2018 and 2021, which is an award given to the top 1% of most influential researchers globally. That's an amazing achievement. Welcome, Richard. CT Standy?
Maybe I'll... Thank you for that kind introduction. Of course I wrote it.
Well,
Regrettably, I gave the wrong one. How boring for you to go through all that. I'm sorry. Sorry to put you through that. It's very tedious. I have this habit of speaking really frankly, and it gets me into a little bit of trouble. But oh well, I've survived this far. I'll try to keep going. But it's really, I'm on the side of hopefully on having an impact. And as I mentioned in the earlier on, and certainly in the workshop, I'm dyslexic, and I've grown up. Well, I grew up thinking that I have a lot of evidence that I was stupid, but for some reason I never believed that. And so I kind of have a French judiciary approach, a French legal approach, that everything is wrong until proven guilty. So like, I don't believe anything. I don't believe a lot of my own work. And a lot of my own work, I don't like to give it to anyone else until I'm absolutely sure it's useful and will have impact. So I think that's the reason why my work has been taken up, because it's typically, I try to make it useful. But I must say, there's very few times I've changed my presentation so much as what I have today, given all the extraordinary presentations earlier today, all the concepts, and just trying to make it, again, useful. And hopefully I've hit the mark. We'll see. All right, great energy in the room. What a great symposium. Let's get going. I'm going to tell you about my dream first. This is an interesting way to start. My dream that all public health interventions are co-created with community health professionals and other stakeholders. That all public health interventions are developed based on unbiased and well-characterised needs of those we're really trying to serve. We have implementation and scaling up strategies that was integral to the design. All public health interventions have are so fit for purpose, they get sucked into practice and evaluated for impact. Impact on people's lives, that people's lives are better. That actually the research that we do it's evaluated for that actually makes people's lives better. And can be implemented equally well by non-expert and expert groups. Whoa, what does that one mean? That us academics develop something that can be easily implemented by anyone in the community, anyone in health services that just want to get on with doing good work. So getting research out of the ivory tower, getting method, good method, making methods egalitarian. All right, that's my dream. I'll show you how I'm trying to go around getting this done. But what is health literacy? Health literacy is a way to understand what are people's health information needs, why some people struggle to look after themselves, why adhering to medications and lifestyle change can be so difficult for some people, what we need to do to improve service quality and effectiveness for all people, why many of our interventions are so ineffective. Well, they're effective for those people they're effective for. They're effective for those people they're effective for. They're easy to reach often. The ones we make it, co-design it with, who are easy to have there around the table at that time. And it's much more than that too. That's just a start perhaps. But actually most of the research we do is not reproducible. 80% of what we do just doesn't get reproduced, doesn't get used again, is not usable, can't be used. This is well shown in preclinical sciences in the laboratory, but it's also the same for public health. Why is that? Well, it's because we don't really release stuff until it's really, really ready, until it's actually fit for purpose. We don't really know what reproducibility is. We don't really care about it in public health institutions because the drivers is for publications. The drivers is to get more grants. The drivers is for your CV. So we don't have really great drivers to have real impact. Is my research reproducible? Well, actually, I found this article because this extraordinary man, Glenn Begley, published this article in Nature, and he gave this presentation about reproducibility. It stirred me up so much. And I realised the mentors I had growing up in my research career were also obsessed with this. So I happened to be tremendously indoctrinated into reproducibility. Does this matter? Of course it matters. It matters a lot. We're using public and private monies all the time. We must do this much more responsibly. So how are programs and policies usually developed? Is there a particular method? Has anyone done a PhD in intervention development sciences here? Is anyone? A PhD in intervention development sciences? Or a master's? Short course? Has anyone ever heard of intervention development sciences before? Two. So, okay, I'm an epidemiologist, I measure stuff, okay? We're getting pretty good at measuring stuff. We measure stuff all the time, we measure it. And then we're good at evaluation. Yeah, we do randomised controlled trials, we do program evaluation, maybe there's realist evaluation now. We can evaluate things. What about this thing in between, the thing that we actually want to implement and evaluate, the sciences around that? So that's what I've been working on. Let's actually develop things that are fit for purpose, wanted, needed, and implementable. So yeah, let's use method to make things more useful for implementation for both programs and policy. Okay, top down, bottom up, my diagram, I'm still working on this diagram, how to communicate this as well as possible. Top-down approach isn't really good enough, is it? We know that, but we could say the bottom-up approach isn't really right one either. So with the top-down approach, we've got governance which is distal from diverse communities. We've got leadership and improvement based on prior evidence. It can protect the community from known harms and implement known benefits. Magnificent things can be done like seatbelts, fluoride in water, mass vaccination. We can do really great big picture things and be tremendously effective, but all the easy things have been done now, haven't they? There's potential for magnificent universal impact, but community engagement and implementation can be disconnected from what's wanted and needed. So a top-down only approach by governments and organisations isn't quite right. Then we've got the other side here, the bottom-up approach. Grassroots movements can be transformational, but participation and engagement can be really fragmented. It may not be everyone in a community. It could be just fragmented groups or particular lobby groups. It can be uncoordinated, not representative, and disconnected from policies and processes. The community activism and advocacy can mobilise resources, change policy, generate much needed change, absolutely can have tremendous impact, thousands of examples around the world. But the governance is distal from the diverse communities again, because what the communities want, what want to have in place may be so different than government priorities, what's possible, what's needed and wanted at that particular time. So we need to have something in between, don't we? We need a top-down and a bottom-up approach. Starting at the top, we need governance coherence between community needs, implementation capability and political imperatives. And the bottom, coordinated and meaningful engagement with implementation across diverse communities. And in the middle, policies and programs matched to what the community needs, wants and can be implemented. So that's kind of what I'm thinking through of how can we get this green thing happening usually. It takes a lot of coordination. So we've had a little bit of success over the last 10, 15 years with developing the affiliate manual, the Optimising Health Literacy and Access Manual for locally and for WHO. Then we developed national health literacy demonstration projects that have been going for a while. There's a few of those around. And we were able to do this terrific program with the Mental Health Commission New South Wales. I'll go through that a little bit later. And then we re-released the affiliate manual last year. We have this terrific report with WHO, and the French government now taking on my recommendations from the WHO report. And there's a new European Commission project, which I can't talk about yet, but it involves a lot of countries at once using this methodology, such that across the whole regions, we begin to see what is sensibly scaled across regions, what should be focused on particular target groups like migrants, and what should perhaps be sensible for sub-regions. If we can have large enough programs which are all developed and evaluated using really clear methods that are seeking to develop something which is implementable and scalable and equitable. So that's part of the breakthrough and some work that's coming up soon. A little bit more on the WHO report. There's a QR code if you want to get a copy of that, but these slides can be easily made available to whoever would like them. And the demonstration projects, the first 16, and then there's some new ones, and there's some upcoming ones in different parts of the world, including that big whopper in Europe. Okay, and now the demonstration project, as Catherine said this morning, is one of the demonstration projects. Okay, a simple key concept, a few concepts I want. Listening, as I mentioned this morning, I reckon listening is really hard. What ears am I using today? What biases are in my ears? What indoctrination I've had through where I happen to be brought up? We all have these. So listening isn't so easy. And we're trying to engage with people, telling them that their diet's bad, they've got to be healthy, but they always live in a smoggy area and they're just worrying about enough food on the table, these social determinants of health. All my friends drink, so you're telling me not to drink and not have friends? So people are just having a life. They're just having a life. And we're telling them, no, you've got risk factors. We're seeing the world through our lens because we have this obligation, this role as health professionals, but it's not necessarily people work. And then we're trying to get them to box themselves into a particular incomprehensible NCD or non-communicable disease. But some people are aware of these links. Other people are not, or they may see a connection, but it's pretty complicated because they happen over a long period of time often. Some people can be completely unaware and reject. So we're working in this really interesting area where we're the health professionals and we're not really able to communicate in a language which really makes sense. And then we've got these diseases which make no sense or may not happen in the future. So I need to get a little lozenge. So you can take over for a bit?
Sure. Speaking from my vast experience as not a clinician or a researcher or an academic, I feel like I can speak as an expert to Richard's work. Are you regretting handing the microphone over yet?
Not at all. I'm trying to have my work be egalitarian and anyone can use it.
Well, it's definitely that.
Right. Applause, please. All right. I was thinking before I started this session, this is the worst session. People, it's the end of the first day, they've travelled here, it's really tough. Anyway, I'll try to keep you going for a while. All right. We've got health literacy of individual. We have community health literacy, and we've got health literacy responsiveness. There's 3 types of health literacy which we defined. Obviously, a person's health literacy is really important, no doubt about it. Irrespective of whatever health literacy a person might have, we need, as health system, health services, health practitioners, carers, friends, to enable people to have the best chance, irrespective of what they need and want and their capability. But then, of course, it's all that people around, all those resources around the people. Many people in society are not making their own decisions, are they? They're making decisions with their family, with their friends. Maybe it's the village matriarch. Maybe it's grandmother, grandfather. So a person could have very low individual health literacy, but they've got amazing community, amazing friends, amazing support, amazing GP, amazing friend down the road. So it's pretty complicated, this health literacy thing, actually. Most people live not in individualistic societies like Australia. They live in communal societies. So individual health literacy overall is perhaps something pretty unimportant overall, globally. 7 of the 8 billion people live in communal societies. And many people in our society are making community decisions. People support them all the time. Some people really, really want their GP to make that decision. And that's the right thing for them to do at that particular time. There's about 5 types of health literacy. We categorise them: accessing, understanding, appraising, remembering, applying. I have 2. So people can have a lot of tasks at different times. Remembering doesn't often appear in the list, but I think it's really important. People have got to remember the right thing to do at the right time. So there's quite a lot of work to do for people. I think we need a really well-considered mix of interventions that to make our work effective for disease prevention and control. How do people actually learn? No, I learn differently. Some people love printed materials. Some people only want to learn by talking to health staff. Some people, it's through media, TV, radio, community conversations, talking with peer group. Maybe it's the Iman, which is the most important. Then through social media apps, or arts and songs can be the most important for some people. And all these might be right for some people at some time, but not other times, or the right mix. And yet, most governments put out more 1 or 2 of these. It's easy, it's quick, looks good. This is a really useful framework. So when we're developing interventions, why don't we just look carefully at the task that's going to be done and look at the kind of materials, the learning styles. These are classic learning styles. Just this alone can produce really, really greatly improved education materials. So I won't go through this in detail, but just to say what people are talking about over dinner or down the pub or wherever, it's incredibly important, the community conversations. We need to use this and build on that. Simple message when developing services or engaging with people about their well-being and their illness, or both management and prevention, use health literacy thinking, please. How people learn, the health literacy tasks, the daily health literacy skills and ability. So we had to measure this, so we developed a way of measuring it, which I mentioned before. So, which is embedded within the Ophelia process, optimising health literacy and access, really trying to connect health literacy thinking to people at all levels of community and co-design, prioritisation, implementation of locally designed fit-for-purpose solutions. It's got 3 steps, which I won't go through in detail. You'll expect to see these in any kind of sensible research program, except we use this very careful process of assessing the mechanisms behind why people might be struggling, or the mechanisms by which they can do some things sometimes. A key point here also is that this tool is a strength-based approach, recognising that some people have strengths sometimes and not other times, but we've got to build on those strengths. Here's the questionnaire, 9 scales, fundamental things. I won't go through many of them, but feeling supported, understood and supported by providers, or social support for health, appraisal health information, ability to find good health information, understanding health information well enough to know what to do, some of the things. So people can have a great mix of these, and we developed a questionnaire, and those people who love questionnaires would recognise this is a pretty special questionnaire. In many languages, we're finding it is more than robust, used in many places. So the Ophelia process is used to develop the mental health literacy project here in New South Wales, in partnership with my university, with the University of New South Wales and University of Newcastle. Some of the people in the room were involved in this, so you could wave at me, and if you're still game, it was a really hard project, a really tremendously hard work. So we're able to get immense amount of data from people, from their hearts and minds using this questionnaire, which have questions which come from the hearts and minds of ordinary people, about ordinary things that people do in their life, not for some interesting academic theory, but actually what's useful for people. This pretty diagram here, this stoplight kind of activity, it's what we have here is different subgroups of people going downwards in these columns. And this is where subgroups of people have been put in the same group with pretty much the same scores on all 9 scales. It's an old-fashioned cluster analysis. Every time a clinician sits down with a client, a patient, they're trying to find out, what's all the special features of this particular person? I need to get my repertoire going. I need to understand who are they, and I'll think about all kinds of people like this I've seen in the past. Yes, I've seen something like this before, and you come up with a solution. So this is a bit like that. Subgroups of people with the same sets of skills, and each of these people need a different kind of solution in some ways, don't they? Because they've got different strengths and different weaknesses and preferences. So here's just one example, the second most challenged person, I guess. So they have also linked to a particular lifestyle. So we actually get a very detailed profile of lots of subgroups within community. And here is a vignette developed from that particular profile called Matt. We give them nice names. We co-design these with the community to make sure they are actually meaningful, short and succinct. Sometimes we're able to make them into videos, entire videos, which are incredibly educational, incredibly emotive. People in the workshop got an opportunity to see this. So I've got several videos. Then we'll ask the community, and these small workshops with quite often with 5, 10 people, And people will often have a wide range of lived experience. In fact, COVID kind of helped us because people were online, very diverse, all kinds of issues, all kinds of places and conditions. And people can veto. If they don't like a video, they can, a story, they can, if it's too stimulating or problematic or it's too close to the heart, they can skip it and they can just go on to the next one. So we ask, first of all, do you recognise this person in the community? What's their main issues? Develop a relationship. What strategies would be used to help this individual? So a community member is asked to use their lived experience. They're looking at the lived experience of someone else and they're just reflecting on their own lived experience. They're using their own expertise, exactly what they've seen in the community around them. We're not asking them anything fancy, nothing academic. Do you recognise this person? Oh, it's like Uncle Joe, he did this. Well, it's like me sometimes. So it's just ordinary people, and in here is embedded those health literacy mechanisms. So we ask, what strategy to help this person? Then if there are lots of people like this in the community, what could you do with lots of people like this in your particular organisation? Because then we get the meta thinking, the systems thinking. Then we get hundreds and hundreds of ideas and we can organise them into changes in individuals and changes that have to happen in the community or in the family, or changes that health staff have to do every day, or changes in policies and programs. So we get really rich detail on how to build a solution across the entire system on the table with the lived experience of people in there on a daily basis, and also our best frontline practitioners, those extraordinary practitioners who really have seen thousands of people come and go, and often people never really ask them to engage in a clinical case like this or a community case like this, where they can really share what they do on a basis. So just the workshops themselves, incredible learning experience for our clinical teams, and often our community members want to be part of the solution. They're so inspired by the ideas they get. The first time I ran this was in Northumbria in England for some reason. And they got aggressive at the end of that. They were so inspired by the ideas, they wanted to be part of the solution. They didn't just want to give the researchers their ideas, they wanted to be part of it. So in developing these sort of interventions, there's always something in the middle which has to be there. It's going to fall over unless we have it. But then there's all this stuff we have to modify around it each time. But in developing this New South Wales Mental Health Literacy Initiative, which was with the 10 PHNs, very, very different organisations, very different, all kinds of levels of interest, of all expertise in some areas of health literacy or not in others, and all kinds of maturity. So we had a very complex project. So how do we find the most important things for all these PHNs? And yes, very different organisations serving a lot of people. We're really seeking to upskill the healthcare professionals right across the state, particularly through PHNs, so that they can improve services and systems systematically. And this is a program logic for those people into program logics. We really try to systematically understand what's going to happen right at the top, right at the top. People who have lived experience of mental health issues and caring families and kinship groups, everyone. The bottom, that people of New South Wales have the best opportunity for good health and well-being and to live well in the community on their own terms, having the service and supports they need to have a full life. That's key directions of key policy document, the Mental Health Commission. So that's what we're aiming for. So what we have in there is stuff that is at the organisational level, stuff at the individual level, and the responsiveness, the matching between what we need to generate the organisation such that we get these changes at the individual level. We built 11 action areas in 3 main groups. Action areas focused on connection between health services and community. Action areas focused on accessing help at the right time in easy, friendly ways. Action areas focus on training and capacity building in health and community services. And there's 11 altogether, and there's actually one also about young people in schools as well. So this was what we generated from an immense number of ideas across New South Wales. From a co-design process where practitioners and people with very diverse lived experience and their carers just put on the table what they think the solution should be for those cases like the MAT. I showed you that little vignette before. Lots and lots, hundreds and hundreds of ideas. And we just organised them like this and checked that they all made sense to them. Under each of these is a long list of how it can actually be done within organisations. So this is what we're putting into a software package for a quality improvement services tool to enable organisations to easily assess and work on one of these or all of these at the same time, or what do they need to do with their organisation. Okay, so we're able to finish our program logic with the mechanism inside, and we're able to do a 3-point transformation program, orientate your organisation, evaluate your organisation, implement training. So lots of lovely videos with local famous people or other people, and lots of vignettes to use too for really to get grounded experience. This is built for a whole wide range of practitioners' services across the state. Okay, I won't be able to go through this in details, but all these 11 action areas have lovely material on them of what to do on Monday morning, practical stuff. Implementation on this, we did about 40 odd different kind of education training kind of ways in which organisations can use these on a daily, weekly, monthly, yearly basis, focusing on what they particularly think is needed or useful by them. So using good educational processes, standard educational processes of really having key learning outcomes and learning processes that practitioners and trainers could use on the day, whenever they need. So I think I'm coming towards the end. It's going to look a bit something like this. So watch this space, keep ringing the commission and support them to keep pushing us to get it out there and work with you. I won't go through this, but just in summary, we really do try to have a strongly principles-based approach. We don't do projects, we don't do pilots, we don't really do programs. We really seek to do transformation. So day one of our projects is day one of scaling up. So we have a very deliberate program to make sure that every step is supporting us to have the material so this could be scaled up. Okay, this is my dream again. So this is my second last slide. So this is the sort of stuff I'm trying to do, that we're doing. Lots of great collaborators from all around Australia and many parts of the world now, really trying to build and improve how we do public health, improve services and health service research. Thank you.
Actually, yes, do we actually have time for a couple of questions if anyone would like to ask Richard a question? Pressure, it is getting to that time of the day. Well, here we go. Welcome.
I was speaking with some senior person from diabetes in Denmark, and they said, this is what we want to do. So this is absolutely built for a person, no Cartesian divide. This is a person who's trying to have a life. They've got a mind and a body. So these are fundamental things. So I would see this, hopefully it's relevant far beyond mental health, far beyond. So thank you for that question to highlight that. Deserved a break. Oh. Just to repeat the question, the WHO has been criticised for being very medical. And not being responsive, and a whole lot of other things I could add to your list there. With this particular report, it is transformational. We're able to say that there's the WHO best buys, which are very medical, all this evidence around them, all this proven, all these randomised controlled trials, but they're designed for Mr. and Mrs. Average, for want of a much better term. And they will, by definition, increase inequalities and leave more people behind. So at least this one report in WHO, which is getting traction, is having impact. At least this one. But there are so many complex drivers so many medical imperatives. It has a long way to go. They do have good strengths in really trying to have nursing as an immensely important community nursing globally, at pushing great things. There's many incredibly good things they're pushing. But it is a slow organisation, and it's not designed. It's designed to respond to countries. Doesn't have any teeth of its own. It's supposed to respond to all the requests of countries. So if we could get our government and many other governments to take a much more sociological and community approach to health and demand that of WHO, then WHO must change, because that's how WHO works as a UN agency. Interesting question. Great questions. Thank you. Oh.
Be really interested in your experience on the importance and the role of language in transformation, and how you've dealt with that aspect of the transformation process.
Oh, this is a fantastic question. So you wouldn't have. Did you know that I've chaired 300 translation meetings for most of the languages in the world? The thing is, some countries they can't get irritated because they don't have a word for irritation. How can you get irritated? There's no word for it. I'm sure there's people here from many other language groups. So with the Australian community, I can only listen with the kind of Aboriginal community with their language. I can only listen from the words and concepts I have. There's a whole lot of words and concepts that they have that I can't communicate to me because I can't hear them. So that's a really important issue. But I think one of the common things in humanity is being connected and being seen. So there are many, many common things. We've just got to recognise some of the mechanisms in the Western world just don't exist in other countries. So I've just spent 6 weeks in Senegal, in West Africa, really trying to understand what is their agenda and what's important to them on a daily basis. I've done this with travellers or Roma people, gypsy groups is politically incorrect term. What's important to them? Family and dancing and love. And we have our agendas. It's actually communicating in a way in which we use language not to put our power upon people, but actually to give power away. The more we can give power away and have the agenda to be the other groups, the more we're going to have impact. But that's so hard for academics. It's so hard for medical people because they so many years to become so important and powerful, etc. There's so much work has to be done on how we engage communities such that we give power and authority away for actions to be taken. So it's very much about languaging, and that we just, in the West and the British West, we don't have languages and ways of giving power away because it's not part of our common vernacular. Oh, great question.
You can hopefully relax now. Thank you so much, Richard.